Thank you all for being here. This will be just a very general introduction, just to give an understanding, if needed, why we need to tackle and control angina. And that not just in patients who have been just diagnosed with coronary artery disease, but those who have had a procedure, those who have had a coronary angiogram or CTCA, and that showed normal or nearly normal coronary arteries. And I'm very glad that Maria George is here. She's organizing an incredible patient group, patients with MINOCA and INOCA, highlighting the importance of this condition. So from the Clarify data, it is clear why it is important to treat angina. As you can see in those patients who had angina at baseline, there was an increased incidence of cardiovascular death and MI or cardiovascular death, and also an increased risk of elective revascularization. While in those who had angina at baseline, but then had the resolution of angina with mostly with medical therapy, you can see that there was no increase in risk, and if anything, a trend towards reduction in all-cause death and revascularization. But what is also extremely important is that in those patients who had no angina at baseline, and then they developed angina during the registry period, then you can see that there was a significant increase, not just of cardiovascular death and MI, cardiovascular death, but also an increased risk of all-cause death and risk of elective revascularization. While that was not the case for all those patients who did not have angina. So you can see that both the presence of angina, the persistence of angina, or the recurrence of angina is associated with increased risk of future cardiovascular events, whilst the resolution of angina reduces this risk significantly. Now, we know that the ischemia trial is a landmark trial. It's a landmark trial. However, it basically reiterates the same concept that we've heard again and again in the past 25 to 30 years, that basically angioplasty is not superior to medical therapy in terms of prognosis. So we know that in patients with stable coronary artery disease, we need an initial assessment, the assessment of risk factors, then non-invasive testing in order to assess the presence of, for example, left main stenosis or significant amount of ischemia. But at the same time, we need to initiate medical therapy. And the pharmacological therapy has two different objectives. On one side is to prevent future events. And for that, there's no anti-anginal that has ever been proven to be effective. So the prevention of future events is done mostly with antiplatelet therapy, then with lipid lowering agents, with antihypertensive and ACE inhibitors. And amongst the ACE inhibitors, we know that the one that has, basically data on patients with coronary artery disease is only perindopril. On the other side, we have the treatment. We also have to treat angina. That we can use short-acting nitrates in those patients where they work for the control of acute episodes of angina, but then all the different medications in association. On that, I will expand a little bit later, because it is important to understand that if we start with one medication, it's better we don't get the full control of angina. We need to use more than one medication. And usually, if we use two hemodynamic agents together, they do not confer any additional benefit. But when we face a patient with chronic coronary syndromes, what should we do? First of all, is a risk stratification and non-invasive test. Then in those patients where we suspect that there is a significant amount of ischemia, then we may need to do a CTCA if we want to exclude the left main stenosis. And then we need to discuss and share with our patients, and that is a very important point. Share the decision, the condition, because there may be patients who may say, oh, well, I just want to have a revascularization. I just want to have an angioplasty. And we have to tell them that they can have an angioplasty, but that does not mean that they shouldn't be receiving drugs anyway. and that they will be receiving anti-anginal drugs anyway. But also there may be patients who may just prefer to take medications. And what is important is to tell patients that they, over their lifetime, they will always have to be medical therapy. Now, if we look on the other hand, what we tend to do, and this is especially what the interventional cardiologists tend to do, is to rush patients to the cath lab before optimizing medical therapy. You can see that 2/3 of patients in this registry received less than one anti-anginal medication before the procedure. So that means that in the vast majority of patients, we tend not to optimize medical therapy before proceeding to coronary angiogram, and only less than something shy of 20% were receiving more than 2 anti-anginal medications. And we know that medications, because if we look at the Orbiter trial, there was a study conducted in patients with class 1 to 4 Canadian. The patients despite the angioplasty, most of them remained with 2 or 3 hemodynamic agents in both arms. We can see, for example, the number of patients who remained on a beta blocker, or patients who remained on a calcium channel blocker, or remained on long-acting nitrates, both in the PCI and in the placebo group. And you can see that they were exactly similar, and that the effect of revascularization on the overall amount of angina was very limited, because there was only an increase, and 30% of patients who had an improvement with PCI. They were completely angina-free. But also, it is important to note here that 15% of patients remained completely asymptomatic, became completely asymptomatic with medical therapy. So that is very important, and it's important because often we face a lot of problems with optimization of medical therapy, especially with beta blockers, calcium channel blockers, and long-acting nitrates. So usually we achieve maximum dose of beta blockers only in 46% of patients. We know that we don't have to use the full dose beta blockers, because what is important is rate reduction, and maybe the association of a beta blocker with ivabradine is better than using full dose of a beta blocker. But also there's a 25% of patients who are intolerant to nitrates. And I have to say, yesterday in my clinic, almost all patients who received chronic nitrates reported terrible headache, and most of them had to stop the nitrates. So that is not so uncommon. It is very frequent, and especially when the warm weather comes. Also, we understand that angina is caused by overlapping mechanisms. We know that 30 to 50% of patients have normal coronary arteries, and in these patients, angina may be related to vasospasm. Probably we have highlighted the importance of vasospasm in the past a bit too much, and we have highlighted vasospastic angina as very frequent, while probably that is much less frequent today, and microvascular angina. So it is even more important, because of that 50%, 90% is made of patients with microvascular angina. But then we have patients overlapping or stable and microvascular angina. And we know that according to the different mechanisms, we cannot fully use most of the anti-anginals, because beta blockers can cause a spasm. They have a detrimental effect on left ventricular and diastolic pressure, and therefore worsen chest pain in patients with microvascular angina. The same with calcium channel blockers and nitrates. They may cause a still phenomenon. Some of them work on microvascular angina, but in the vast majority of cases, they are completely neutral on microvascular angina. And nitrates may even increase microvascular disease and increase long-term cardiovascular risk. Now, 2019 guidelines on the chronic stable angina were a little bit confusing in terms of messages, because they gave all different messages that often did not match one with the other, but they were clear in saying that there's not being a single trial that has demonstrated the benefit on one anginal medication compared to the other, and that the combination of anti-anginal agent with hemodynamic action has not any additive value. So that is something important, but also they identify the fact that the first optimal medical therapy is that therapy that satisfactorily controls symptoms with maximal patient adherence. So that is a very important point. In fact, they've introduced for the first time in the ESC guidelines the importance of patient compliance into the guidelines. It is important to have a patient-tailored approach because we're not treating the disease, we're not treating the symptom, we are treating that patient in its entirety. That is, and therefore, we need to understand what are the side effects, what are the expectations from each patient. And also, the guidelines say that the best approach for medical therapy is to use combination therapy rather than using one single drug. Given that the hemodynamic agents together have no additive effect, it's clear that we need to add an hemodynamic agent with a non-hemodynamic agent. Now, we've gone through different proposals over the years on how to treat and manage angina. We went through the diamond approach that was a first attempt that we made to personalize the treatment of patients with ischemic heart disease. More recently, together with Athanasiou Manolis, we developed this other algorithm. We start from the heart rate, and then we combine heart rate and blood pressure to identify the therapy that is most suitable. But what is important is that when, apart from stratifying patients according to the heart rate and blood pressure, we also stratify according to the different characteristics. And you see that in the vast majority of patients, there are drugs like ivabradine and trimetazidine that are always, in the vast majority of cases, suggested as the mainstay of therapy. Despite all this knowledge, we know that we don't treat our patients adequately, and at least half of our patients with chronic coronary syndromes, at least one episode of angina a month. But also we have to understand that angina is not just the classical angina that we get as retrosternal chest pain. It is reported as arm pain, reported as shortness of breath, tightness, fatigue, headache. And also we need to understand that cultural differences in the way patients report their chest pain. I practice in a big hospital, teaching hospital in South London, where we have a very diverse population. And when you hear upper-class British patient coming and they refer to the chest pain as a tightness, well, see, when we get patients from Southeast Asia, they tend to say that they have gas or some sense of fullness. So you see the way of patients reporting symptoms is different. So we need to understand to listen to our patients and trying to understand symptoms. However, despite that, we need to also teach them medical therapy is only part of the medications. Other part of the control of the angina is on lifestyle with using proper diet, exercising properly, stopping smoking. Because in real life, and we've conducted an interview in patients with stable angina across the globe, the feedback that we get from our patients is that we don't give enough information and treatment. There's not enough time to discuss, and that has an effect on adherence. Because the most important thing in adherence is that patients feel that doctors are convinced of what they're saying. So if they feel that doctors are convinced on suggesting medical therapy and specific medical therapy, so that is the best way of getting those patients to be adherent. And so when we interviewed patients, we've seen that very rarely have been taught about lifestyle changes, diet, about the mechanisms of the disease. Few patients recalled that to being told on the mechanism of actions and side effects of the drugs. And very few patients received coaching on lifestyle. Almost none had received support, emotional support, to overcome health issues often linked with the disease. So that is important because it's if patients are not convinced and they are not informed properly and they are not sharing the decisions, then very low adherence. And you can see that in patients who have are less adherent, they want to have more information. They tend to do less exercise. They continue often to smoke. And this is why we are here today to discuss how best we can implement the not just the medical therapy, but because medical therapy is just one of the type of approach. Why is one of approach of the multiple approach for patients with angina. And I will stop here.